Hello everyone, my name is Victoria and I am a PA student nearing the end of my clinical year. Currently, I am studying for my end of curriculum exam and for the Pance. Throughout the past year, one of my favorite ways to study was through audio study guides, mostly because I'm a victim of the very long commutes to my rotations. So I decided to make my own after I ran out of ones to listen to, but also after I decided that I wanted a more comprehensive guide, especially one that is specifically geared for the Pance or for an EOR exam. So, this is my audio guide for the gynecology portion of the women's health EOR and for the reproductive section of the Pance. I'm going to go through these topics roughly in the order they're in for the PAEA Women's Health Blueprint. So let's start off with normal physiology. So, normal menstruation has two components, the ovarian cycle and the endometrial cycle. I'm going to go over these one at a time and then link them at the end. So, the ovarian cycle has two phases with ovulation in the middle. So the follicular phase is first. It's days 1 through 12, and it begins with menstruation. Then pulsatile GnRH from the hypothalamus leads to increased FSH and LH from the pituitary gland, which then moves to the ovaries. In the ovary, FSH leads to follicle and egg maturation, and LH leads to production of estrogen by the maturing follicle in the ovary. Increased estrogen then acts as a negative feedback loop on the pituitary gland and hypothalamus, which then causes the inhibition of LH and FSH. And basically, what this does is it stops any additional follicles from maturing. On days 12 through 14, ovulation occurs. The negative feedback switches back to a positive feedback, and it causes increased estrogen, which then leads to increased GnRH, ultimately leading to an increase in estrogen, FSH, and LH. An LH surge causes release of the egg from the follicle, which is what we know as ovulation. The luteal phase is days 14 to 28. So, with the LH surge, as I just said, the ruptured follicle with ovulation, then it becomes the corpus luteum in the luteal phase. The corpus luteum secretes primarily progesterone, but also estrogen, and it causes the switch back from a positive to a negative feedback on GnRH, LH, and FSH. So those three decrease. The next step depends on whether the person becomes pregnant or if they don't. So with pregnancy, the blastocyst causes the corpus luteum to keep secreting estrogen and progesterone, and this will prevent menstruation. If pregnancy does not occur, then the corpus luteum deteriorates and becomes the corpus albicans. This leads to a decrease in progesterone and estrogen because the corpus luteum is not making them anymore. And ultimately, this will cause menstruation and a cessation of the feedback on the hypothalamus and pituitary gland. So it'll restart the pulsatile GnRH secretion, which causes increased FSH and LH, which leads to follicle maturation. And if you couldn't tell, we're restarting the cycle. So the endometrial cycle is next. The proliferative phase is days 1 through 12. The GnRH pulses causes the increased LH and ultimately will lead to estrogen production by the maturing follicle. This increased estrogen stimulates the growth or proliferation of the endometrium. The secretory phase is days 14 through 28. The LH surge causes the development of the corpus luteum, which produces progesterone and estrogen, and this will maintain the endometrial lining. Next, pregnancy or menstruation will occur. So, If the corpus luteum keeps secreting its hormones, there will not be any sloughing of the endometrium, so no menstruation. If menstruation does occur, then the patient is not pregnant. There was a fall of progesterone and estrogen from the deterioration of the corpus luteum, mostly because there was no maintenance of the endometrium. So to connect these, first, this image shows the fluctuation in the hormone levels, and then there is an illustration of the development of a follicle. And then this is just a little bit more on the endometrial cycle, which ultimately is very simple compared to the ovarian one. To connect them all back together, the follicular phase and proliferative phase are occurring at the same time. The follicle is preparing for ovulation, and the endometrium is preparing for implantation. The secretory phase begins with the development of the corpus luteum in the luteal phase, and that's when either pregnancy or menstruation occurs. Menstruation occurs with the development of the corpus albicans, and then that will start the follicular phase. So now let's get into menstrual disorders. So I'm going to start this off with a question. What is the most common cause of secondary amenorrhea? I'll give you 5 more seconds. The answer is pregnancy. Okay, so let's start with amenorrhea, which can further be narrowed down into primary or secondary amenorrhea. So to start with primary, the definition is failure of menarche onset by age 15 when the patient does have secondary sex characteristics such as breast development and pubic hair growth, or failure of menarche onset by age 13 in patients without secondary sex characteristics. For the workup of these patients, the two most important tests are a beta HCG to test for pregnancy and an FSH level. Two other common initial tests include a TSH and a prolactin. For etiologies of primary amenorrhea, for patients with secondary sex characteristics, so they do have breast development, they either have a present uterus or they have no uterus. If they do not have a uterus, the next step is to order a karyotype analysis. In the case where the karyotype analysis shows 46XY, this indicates androgen insensitivity syndrome, which would also show an elevated testosterone. The patient might have testes on exam or on ultrasound, and their FSH will be normal. For a 46XX karyotype, this would indicate Mullerian agenesis, which would have a normal testosterone and FSH. For patients with a present uterus, this would indicate an outflow obstruction. So basically, the patient is developing normally, but there is something blocking their period from coming out, for lack of better terms. So, causes of this might be an imperforate hymen or a transverse vaginal septum. This would cause all of the labs to be normal, like a normal FSH, GnRH, and LH. Ultrasound or an MRI may show blood in the uterus, which is called hematometra, or blood in the vagina, which is called hematocolpos. If there is no obstruction, then move on and evaluate this as secondary amenorrhea. So that was how you work up if there is secondary sex characteristics. If the patient does not have any breast growth or any pubic hair development, or if they're just in very early Tanner stages for their age, then you should proceed with a measurement of FSH and LH. Low or normal FSH or LH indicates hypogonadotropic hypogonadism, which is an umbrella diagnosis. It's something that is caused by a different disorder. So this would be caused by problems with the hypothalamus or pituitary gland, low caloric intake, excessive exercise, or an overall puberty delay. So if in a puberty delay there is hypogonadotropic hypogonadism, you will also see a low estrogen and low progesterone at prepubertal levels. For a high FSH and LH, this would mean hypergonadotropic hypogonadism, which indicates that the ovaries are not producing estrogen. From here, you would order a karyotype analysis. So for the karyotype 46XY, this would indicate Sawyer syndrome. For 45X, this means there is a non-functioning or a mutated X in 46XX. That indicates Turner syndrome. For 46XX, that indicates premature ovarian failure. Now moving on to secondary amenorrhea. The definition is absence of menses for 3 or more months in a patient with previously normal menstruation, or an absence of menses for 6 or more months in a patient with previously abnormal cycles. So cycles that wouldn't come monthly, or they were kind of sporadic. So most common etiology, as we already have said, pregnancy, but this is not all that might cause it. So first we'll talk about functional hypothalamic amenorrhea. This is a puberty delay seen in athletes, patients with anorexia, patients with serious illness. Think here about the female athlete triad, which is hypothalamic amenorrhea, an eating disorder, and osteoporosis secondary to an estrogen deficiency. It could also be caused by pituitary dysfunction. So this would be a prolactinoma or a pituitary infarct, like in Sheehan syndrome. And on labs, you would see a decreased FSH, LH, and estrogen. Ovarian dysfunction is another cause. So this might indicate PCOS, premature ovarian failure, so follicular failure or follicular resistance to LH or FSH. Or it could mean Turner syndrome, which on labs would have low estrogen and increased FSH and LH. There might be symptoms of low estrogen in these patients, such as hot flashes, things that look like menopause. Uterine dysfunction is acquired endometrial scarring secondary to postpartum hemorrhage, a D&C, or an endometrial infection. This is called Asherman syndrome, which is indicated by the absence of the normal uterine stripe on a pelvic ultrasound. Other causes of secondary amenorrhea are hypothyroidism and obesity. So, in the workup of secondary amenorrhea, the best initial test is beta HCG every time. If this is negative, then proceed with a serum prolactin, FSH, LH, TSH, and estrogen. If FSH is increased, this suggests primary ovarian insufficiency. If TSH is increased, that suggests hypothyroidism. And an increased prolactin suggests a pituitary disorder, so order a pituitary MRI. At a testosterone level, if there's signs of hyperandrogenism, such as hirsutism or facial hair growth. Other workup, if the diagnosis is not clear, includes a progestin challenge, which is 10 days of progestin. So when you stop the progestin after those 10 days, some patients will get bleeding, which is called withdrawal bleeding. This is a positive test for a progestin challenge. This indicates that an ovulation is likely caused by non-cyclic gonadotropin secretion. So you would order an LH. High LH indicates PCOS. That would be a mild elevation, or premature menopause would be a moderate to severe elevation in LH. If the LH is low, this would just be idiopathic anovulation. If there is no withdrawal bleed, order an FSH. High FSH indicates hypergonadotropic hypogonadism and ovarian failure. Low FSH indicates that you should order an cyclic estrogen progesterone test. With this, you might have withdrawal bleeding or not. Withdrawal bleeding indicates hypogonadotropic hypogonadism, and no bleeding suggests endometrial or anatomic problems. The management of secondary amenorrhea really depends on the etiology. For a hypothalamic etiology, you want to reverse the underlying cause, induce ovulation with gonadotropins if trying to conceive, and if not trying to conceive, oral contraceptives. Tumors, you want to excise them. Medical treatment of prolactinomas includes cabergoline or bromocriptine. For premature ovarian failure under the age of 40 years, this indicates the uterus is present, so then you want to treat with combined oral contraceptives or estrogen, in addition to progestin replacement therapy. Okay, so now moving on to dysmenorrhea. There's primary and secondary, just as there was for amenorrhea. Primary is menstrual pain during ovulation cycles in the absence of pathological findings. It's caused by uterine vasoconstriction, anoxia, and sustained contractions from excess prostaglandins. It'll usually start 1 to 2 years after the first period in teenagers and before age 25. Secondary is due to a pelvic or uterine pathology, such as endometriosis, PID, adenomyosis, or ileomyoma. Symptoms include recurrent cramping, midline, lower abdominal, or pelvic pain 1 to 2 days before or at the onset of menses that gradually diminishes over 12 to 72 hours. It may or may not have radiation of that pain to the lower back and the thighs. It's associated with headaches, nausea, and vomiting. In primary dysmenorrhea, the physical exam is normal, but in secondary, there may be signs of the underlying disease, such as an enlarged uterus, cervical motion tenderness, other speculum tenderness, or discharge, for example. Diagnosis: you don't normally need to order any tests, but in patients where secondary disease is suspected, then order a transvaginal ultrasound. The management: first, supportive measures include heat compresses, vitamin B and E started 2 days before and 3 days into menses, exercise, and reassurance. The first-line medical management are NSAIDs, started prior to pain and then given for 2 to 3 days into menses, or estrogen, progestin, contraceptive pills, or progestin only. If unresponsive to 3 cycles of initial therapy, consider laparoscopy to rule out secondary causes. The most common in young patients are PID, or pelvic inflammatory disease, and endometriosis. Next, we'll talk about abnormal uterine bleeding. The definition is an unexplained abnormal bleeding in a non-pregnant woman that pertains to quantity, schedule, or duration. So it's abnormal in how much they're bleeding, when they're bleeding, or for how long they're bleeding. So, some quick definitions. Oligomenorrhea is an increased length of time between menses. between 35 and 90 days. If it exceeds 90 days, now we're in amenorrhea territory, right? Based on the definition of secondary amenorrhea, that's absence of menses for 3 or more months. So polymenorrhea is a menstrual cycle under 21 days. The normal average for a woman is 28. Menorrhagia is an increased amount of flow, so this would be over 80 milliliters per cycle, or prolonged bleeding, which is a period over 8 days. Metrorrhagia is bleeding between periods, and then menometrorrhagia is excessive and irregular bleeding. The etiologies, the most common is anovulatory, so production of estrogen by the ovaries despite no ovulation or corpus luteum formation. The unopposed estrogen causes endometrial growth and proliferation, which then causes unpredictable shedding after it outgrows its blood supply. So there's an acronym to remember the causes. Structural etiologies, the acronym is PALM, P-A-L-M, and then for non-structural, it's COIN, spelled C-O-E-I-N. So for structural etiologies, polyps, adenomyosis, leiomyomas, and malignancy / hyperplasia, but that doesn't go in the acronym. Non-structural etiologies for COIN, coagulopathy, ovulation dysfunction, endometrial, iatrogenic, or caused by a health practitioner, and then not otherwise classified. Clinical manifestations include abnormal bleeding and, if severe enough, anemia. The physical exam is relatively normal, except for if it's pointing towards any specific secondary cause. So, working up this disorder. Labs will include beta HCG, CBC, TSH, and STI screens if indicated. There is no direct test for abnormal uterine bleeding, but the exam and clinical manifestations should kind of guide you towards what you want to order. The initial imaging is usually a transvaginal ultrasound. Should be ordered if secondary etiology is suspected or if the patient is unresponsive to initial treatment. Endometrial sampling should be ordered in high-risk cases. So patients who are over 45, they have a history of unopposed estrogen exposure, history of hypertension or diabetes, or if they're having postmenopausal bleeding. The high risk is for hyperplasia and malignancy. So you want a biopsy to rule out an endometrial carcinoma. In general, consider postmenopausal bleeding to be cancer until proven otherwise by endometrial sampling, aka an endometrial biopsy. So management can be split into 2 groups: acute management of hemorrhage or chronic management. In an OB/GYN rotation, at least in my experience, you are much more likely to see the chronic management than the acute. But we'll start there with acute hemorrhage. The first line is IV high-dose conjugated equine estrogen or a high-dose combined oral contraceptive or oral progestin. Then you could try IV tranexamic acid, which prevents fibrin degradation. A mechanical option is a uterine tamponade, and for persistent bleeding, consider dilation and curettage or uterine artery embolization. For chronic management, first line is estrogen progestin contraceptive pills. These stabilize the endometrial proliferation and shedding, they suppress endometrial development, regulate menses, and decrease bleeding overall. If estrogen is contraindicated, for example, if a patient has a history of a DVT or PE, then consider progesterone-only medications. So the most effective long-term would be the levonorgestrel releasing IUD. If the patient is unwilling or unable to use hormonal treatments, then NSAIDs can help with or without tranexamic acid, or tranexamic acid can be used on its own. Surgical management options are indicated in patients unresponsive to medical management, and the options are endometrial ablation or uterine artery embolization. The definitive management of abnormal uterine bleeding is a hysterectomy. Now, let's talk about menopause. The definition is cessation of menses for over 1 year due to a loss of ovarian function. This leads to decreased estrogen and progesterone production. On average, this occurs at age 50 to 52, but premature menopause is considered to be under the age of 40. Perimenopause is the time when fertility is waning and the menstrual cycle becomes a little bit more irregular, but it hasn't quite stopped yet. Clinical features are secondary to estrogen deficiency. So patients might complain of menstrual cycle changes, vasomotor instability. This manifests as hot flashes, which is the most common perimenopausal symptom. There may also be sleep disturbances, mood changes, hyperlipidemia, increased risk of cardiovascular events, osteoporosis, painful intercourse, vaginal atrophy, or urinary incontinence. On exam, there may be dry or thin skin, vaginal atrophy, and a thin vaginal mucosa, and a decrease in breast size. For the diagnosis of menopause, the most sensitive initial test is an FSH assay, which shows increased serum FSH. Other findings include an increased LH, decreased estrogen, and unchanged androstenedione. I try my best to pronounce that. Complications include osteoporosis, hyperlipidemia, and the increased cardiovascular risk. Management is aimed to relieve symptoms of the vasomotor insufficiency / hot flashes. First line is hormone replacement therapy. If the patient does have their uterus, meaning they haven't had a hysterectomy, then use estrogen and progestin hormone replacement. But if they have had a hysterectomy or they don't have their uterus, then you could use estrogen only. For second line, consider SSRIs or gabapentin and topical estrogen cream for vaginal dryness. Premenstrual syndrome. So the definition is a cluster of physical, behavioral, and mood changes with cyclical occurrence during the luteal phase of the menstrual cycle. Clinical manifestations can be broken down into physical, emotional, and behavioral. Physical symptoms include bloating and fatigue, which are the most common, but you might also see breast swelling and tenderness, weight gain, headaches, and muscle or joint pain. Emotional symptoms include irritability, which is the most common, but also tension, depression, anxiety, hostility, and libido changes. Behavioral symptoms include food cravings, poor concentration, noise sensitivity, and a loss of motor senses. The diagnosis is clinical. The symptoms occur for 1 to 2 weeks before menses, so during the luteal phase, and are relieved within 2 to 3 days of the menses onset, so on days 2 or 3 of the patient's period. And there must be at least 7 days without symptoms during the follicular phase. So, for example, in the 7 days following a patient's period, or 7 days after that, they cannot be having symptoms in order to be diagnosed with this. So, because that can be pretty hard to track and hard for a patient to remember, you could recommend a symptom diary for patients. I know they have this also for patients with iPhones. I don't know about other phones, but you could track your symptoms along with your cycle, and that would help to determine the relationship between a menstrual cycle and symptoms. So, treatment, there's a lot of different options here. The first are lifestyle modifications, so stress reduction, relaxation techniques, exercise, and you could try reducing caffeine, alcohol, cigarettes, and salt. For medical therapy, the first line for emotional symptoms, and it's also causing dysfunction in the patient's life, SSRIs, which fluoxetine and sertraline are the most common. Second line, or if the patient is opposed to SSRIs or if they just want contraception, then you could try oral contraceptives, which stops the cyclical fluctuations in hormones, which then prevents symptoms. Third line, if unresponsive to SSRIs and oral contraceptive pills, then you could try gonadotropin releasing hormone agonists with low dose estrogen progestin add back therapy. Okay, so let's talk about the last topic in the menstrual disorders, premenstrual dysphoric disorder. So this is just a severe form of premenstrual syndrome, but there is more functional impairment where anger, irritability, and internal tension are prominent. Clinical manifestations are very similar to premenstrual syndrome or PMS, but worse. So it's easier to review during the diagnosis portion from the DSM-5, which I'm about to get into, really, because for anyone who's ever read the DSM-5, the diagnostic criteria are basically just symptoms. So this might get a little bit confusing, but I'll try and simplify it as much as I can. So first criteria is the patient needs to have at least 5 symptoms during the week before menses in the majority of menstrual cycles. So, in more cycles than not, there needs to be 5 symptoms during the week before menses, and they start to improve within the first few days of menses, and there are minimal or absent symptoms in the week following menses. So, you need to have 5 symptoms total with at least 1 in each of the 2 categories. So this is category 1. Marked affective lability, which basically means mood swings, feeling suddenly sad or tearful, increased sensitivity to rejection, marked irritability or anger, or increased interpersonal conflicts is a representation of that. Markedly depressed mood, feelings of hopelessness or self-deprecation. And then the fourth symptom here is marked anxiety, tension, or feelings of being on edge. So that was category 1 of symptoms. The patient needs to have at least one of those to have premenstrual dysphoric disorder. So category 2, 1 or more of the following: decreased interest in usual activities, a subjective difficulty in concentration, lethargy, easy fatigability, or marked lack of energy, a marked change in appetite, overeating, or food cravings, hypersomnia or insomnia, feeling overwhelmed or out of control, and then lastly, physical symptoms, including breast tenderness or swelling, joint or muscle pain, abdominal bloating, or sensation of weight gain. So that was category 2. And then again, to revisit the criteria, there needs to be a total of 5 symptoms with at least 1 from each of those categories. So the severity, in order to be diagnosed with this disorder, there needs to be clinically significant distress or interference with the daily activities or relationships with others. It cannot be due to exacerbations of other disorders, such as major depressive disorder, and not due to the physiological effects of a substance or other medical conditions like thyroid disease. This is not in the DSM-5, but another thing that could help with the diagnosis is the symptom diary I was talking about for premenstrual syndrome. So the treatment is pretty much the same for PMS. SSRIs are first line, then oral contraceptive pills. You can consider oral contraceptives first if the patient just wants contraception. GnRH agonists with estrogen, progestin add-back therapy is last line. Combined oral contraceptive pills containing drospirenone are more effective than other combined oral contraceptives. That's just an important thing to note here and to remember. The oral contraceptives containing drospirenone are more effective for PMDD. Okay, so now we have reached the infectious diseases section. So let's start with vaginitis. And first, we're going to talk broadly, and then we're going to get more into the specific etiologies. So, the definition of vaginitis, it's a spectrum of conditions causing vulvovaginal symptoms such as itching, burning, irritation, or abnormal discharge. Etiologies, the most common are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. In general, the manifestations include changes in vaginal discharge, malodor, pruritus, irritation, burning, swelling, dyspareunia, which is painful intercourse, dysuria. And the dysuria or painful urination, they're less likely to have urine urgency and frequency, but it's not impossible. Normal discharge. So in the mid-cycle with the estrogen surge, the discharge is clear, elastic, and mucoid. But in the luteal phase or during pregnancy, it's a little bit thicker, it's white, and it might adhere to the vaginal wall. So those are what the normal discharge would look like. And that's what you can compare discharge to. And then that's how you would decide if it's abnormal. So, diagnosis in general. Physical exam, you need to do a thorough exam of the vulva, the vaginal walls, and the cervix. The workup, so according to like a textbook, so like clinical testing, you're supposed to do during the appointment, it would be the vaginal pH test, the amine, quote unquote, whiff test, saline wet mount, or a 10% potassium hydroxide microscopy or KOH prep. Those are things like, according to probably the exam, that's what you should be doing to work up vaginitis. The clinical reality is that there's such thing as a Sure swab, and it's just a swab of the vaginal walls 2 inches past the introitus, which is the opening of the vaginal canal. You swab for 10 to 30 seconds, and this tests for all of it. It uses transcription-mediated amplification, or TMA, real-time PCR, dual kinetic assay, DKA, or target capture. So it tests for chlamydia and gonorrhea via TMA, bacterial vaginosis via PCR, Trichomonas vaginalis via TMA, and candidiasis via PCR. So, also in the swab, the etiologies of bacterial vaginosis, they test for lactobacillus species, Atopium vaginae, Megasphaera species, and Gardnerella vaginalis. And then for candidiasis, they test for C. albicans, but also C. glabrata, C. tropicalis, and C. parapsilosis. If there is purulent discharge, and there's numerous leukocytes on the wet prep, cervical friability, or any symptoms of pelvic inflammatory disease, move on from vaginitis and work this up as cervicitis. So, specific etiologies of vaginitis. Bacterial vaginosis is first. It is not an infection or a sexually transmitted infection. BV is a shift in the vaginal flora. It's usually an increase in anaerobes, the most common being Gardnerella, and a decrease in Lactobacillus acidophilus, which is meant to maintain the vaginal pH. Epidemiology, so risk factors include pregnancy, multiple sex partners, female sexual partners, frequent douching or washing of the vagina with water with or without soap. So on history, increased malodorous discharge that's worse after sex and worse during menses. It does not usually cause itchiness, painful urination, painful sex, or burning, but it can. On exam, there's mild vulvar irritation with a homogeneous grayish-white fishy odor discharge. So diagnosis. Wet mount, you're going to see clue cells. These are epithelial cells coated with coccobacilli. And there's a way to remember. You also can do the whiff test. Okay. And I was reading the USMLE book, and this is how they remembered this test. And I thought it was so funny. They said, no clue why I smell fish in the vagina garden. I guess that's supposed to help you remember the whiff test. That's so stupid. But I included an image here of the clue cells on wet mount in case you get it on your EOR. That is what it would look like. So BV is a clinical diagnosis technically. So you use something called the AMSL criteria, and you need to have at least 3 of the 4 criteria for a clinical diagnosis. Criteria number 1 is copious, thin, homogeneous, grayish-white vaginal discharge. Criteria 2 is a vaginal pH over 4.5. 3 is a positive whiff amine test or a fishy odor when 10% KOH is added. Don't forget, no clue why I smell fish in the vagina garden. Clue cells and then, fishy odor. And then criteria 4, over 20% clue cells on saline wet mount is the single best predictor of BV. But you might also see very few white blood cells, so that indicates that's non-inflammatory, and few lactobacilli. Another way you could diagnose, or just another tool to diagnose on microscopy, like I said, you'll see few white blood cells, very few polymorphonuclear leukocytes, and lactobacilli. Treatment. So, oral or vaginal metronidazole is the gold standard or first line. So if you're going to go with oral treatment, it's 500 milligrams twice a day for 7 days. Or for vaginal, it's 7.75% gel applied once daily for 5 days. You can also use vaginal clindamycin, and there's no need to treat partners or people who are asymptomatic, and non-pregnant women, you don't need to treat them. Complications associated with BV, it might be dependent on the causative strain, can cause pelvic inflammatory disease. If pregnant, it could cause chorioamnionitis, which is infection of the amniotic cavity, or endometritis, or preterm delivery. While I was reading about these complications, it appears to me to be somewhat controversial. So, real quick, let's touch on metronidazole, which is the treatment for BV. There's a few things to know in case you're asked about it on your EOR. So the mechanism of action, so it forms toxic metabolites and free radicals that damage the DNA of the bacteria and inhibit bacterial DNA synthesis. In anaerobic bacteria, the medication is activated by a chemical, I guess, compound substance present in the bacteria called ferredoxin. And this forms reactive cytotoxic products, which then does the same thing. So, for indications, vaginitis, vaginosis, and then some abdominal infections, that's where you're going to see this drug. Adverse reactions, this is what's really important. So, the most common include a headache, nausea, vomiting, metallic taste, peripheral neuropathy, diarrhea, and confusion. Now, this is the one I've been asked about during practice questions, I'm sure on an exam in school. It can also cause a disulfiram-like reaction when used with alcohol. Basically, when used with alcohol, it causes acetaldehyde accumulation. So it should be avoided during treatment, or else you're going to have a very gruesome experience. Basically, just really down horrendous nausea and vomiting. So it could also cause a transient like darkening of the urine to like a deep red brown color. So that is something that patients should know about. Okay, next, we're done with BV. Trichomoniasis. Etiology, they are protozoal flagellates. This is Trichomonas vaginalis, right? And it is considered an STD. Risk factors include unprotected intercourse and multiple sex partners. History, so you're going to have those symptoms of vaginitis we outlined earlier, but you might also have symptoms of cystitis or cervicitis. The main like key words here are copious malodorous discharge, worse with menses. You're going to have postcoital bleeding, dyspareunia, painful intercourse, dysuria, might have frequency, vaginal pruritus or itchiness, or erythema. Men are usually asymptomatic, but they can develop urethritis or itchiness after intercourse. So, exam, you might see petechiae in the upper vagina and on the cervix. This is called strawberry cervix. And profuse, malodorous, yellow-green, frothy, keyword frothy, discharge and vaginal inflammation. So, work up here. Saline wet mount, you're going to see a mobile protozoan trophozoites with one flagellum. So, take a look here on this photo I included. That is exactly what it looks like. The flagella, also note that it kind of sticks out of the cell, if you could see that. Like, it's just slightly longer. The bacteria, I mean, it's just slightly longer than the actual cell. And that's what it's going to look like if you get a photo of that. So the vaginal pH will be over 4.5. It's usually, when you're seeing it, it's usually 5 to 6 for trichomoniasis. There will be increased white blood cells. If the wet mount is negative, but there's significant clinical signs, then proceed to order a nucleic acid amplification test or a culture. Treatment here, so a single dose of oral metronidazole, so that's 2 grams, or you could use tinidazole. You could also use metronidazole for 500 milligrams twice a day for 7 days. Should treat asymptomatic men and women, and you should treat partners to prevent the ping pong effect, which is the passing of STDs from one partner to the next, and then they pass back, and then, endless cycle. So it could, and for that reason, it can be very difficult to treat. There's a very high reinfection rate, so make sure you retest within 3 months of treatment. And if there is reinfection, treat with the 7-day course of metronidazole. Skip the single dose option. Like, no more single dose the second time that you get it. If you do get reinfected, go with the 7-day course. And the complications are the same as BV. Candidiasis is next. So, etiology, the most common is Candida albicans, and this in general is the most common opportunistic pathogen. When I talk about HIV later, we're going to see that for sure. Risk factors include really anything that will cause immunocompromise. So diabetes, HIV, and then also other risk factors include antibiotic use, pregnancy, corticosteroid use, that also fits with the immunocompromise, oral contraceptive use, increased frequency of intercourse, or tight-fitting, unbreathable, quote-unquote, clothing, in a humid environment. So, history. Listen up. Itchiness. Main thing here is itchiness, itchiness, itchiness. You might also have dysuria, burning, and increased discharge. The discharge will be like thick, white, cottage cheese-like, without odor, but itchiness is the main thing here. So you're also on exam. You might see erythematous vulva and vagina with or without excoriations, which is basically scratches. That would be from itching, not the candidiasis causing it itself, but the patient itching because it itches so bad. Wet mount, you're going to see budding yeast or hyphae. The KOH prep shows pseudohyphae, and I have a photo of that here. So the KOH prep with pseudohyphae, it's like called like the right budding yeast, and I really think in the image, maybe it's just me, but to me it really does look like tree branches, kind of like branching, and then with little like leaf or flower buds like on the tree branches. So that's always what I've used to identify a candida infection on an exam. I feel like this is a pretty distinct looking image. So, treatment. A topical azole, which you could buy over the counter, or an oral fluconazole, which would be 2 doses. Side effects of fluconazole include nausea, rash, hair loss or slash alopecia, and headaches. But if you're going to get asked about anything on an exam, it is likely that the main, I guess, unique side effect of fluconazole includes hepatitis. So, next, atrophic vaginitis. This is not an STD. This is seen in hypoestrogenic states, so low estrogen. And best example of this is menopause, but it could also be in postpartum women or people with progesterone-only contraceptives. So, clinical manifestations: vaginal dryness, painful intercourse, vaginal inflammation, and then recurrent UTIs due to increased pH. Overall, it leads to the loss of the lactobacilli, which normally converts glucose to lactic acid, and that would be what keeps the low pH. And that's why you get increased UTIs, but that's neither here nor there. Management: vaginal moisturizers will improve symptoms like the painful intercourse and dryness, but it really doesn't affect the atrophy of the skin and tissue there. Topical vaginal estrogens are the safest and most effective medical therapy. So this comes in a cream, vaginal rings, or vaginal troches. Adverse effects include vaginal bleeding, breast pain, nausea. It can still cause thromboembolism, even though it's not oral, but the risk is lower. And it does increase marginally the production of coagulation factors, but like I said, not as much as oral estrogen. Then there is something called espemifene. This is a selective estrogen receptor modulator, or SERM, that is an estrogen agonist in the vagina and bone, and an estrogen antagonist in the breast and uterus. This is another option, but like I said, why would you choose something that's not topical estrogen if it's the safest and most effective? So, next, we're almost done with vaginitis. Cytolytic vaginitis. This is an overgrowth of lactobacilli. So whatever BV was, this is the opposite. You're going to see vaginal or vulvar itchiness and burning, maybe some painful urination, a non-odorous discharge that's white to opaque. pH will be normal, like 3.8 to 4.2. There will be copious lactobacilli on a microscopic exam or on wet prep. And then management, discontinue tampon usage to decrease the vaginal acidity. And then patients can either do sitz baths with sodium bicarb, or, I mean, I wouldn't recommend this, but it is said that you could treat it with like douching with sodium bicarb. I'd stick to the sitz baths. But that's all just to normalize the pH, because really what's happening is instead of too alkalinic, it's too acidic. Okay, at long last, we have made it to cervicitis. So, in general, similar to vaginitis, we're going to start with general and then move into more specific things. So, cervicitis in general, inflammation of the cervix, done. Etiologies, so it could be infectious or non-infectious. The most common infectious etiologies are chlamydia, gonococcus, trich, and HSV. And if I say trich throughout this PowerPoint, I am meaning trichomoniasis, by the way. HSV is herpes simplex. Non-infectious includes trauma, radiation exposure, and malignancy. General symptoms include vaginal bleeding between periods, aka spotting, or after intercourse, purulent vaginal discharge, painful intercourse, pelvic pain or pressure, painful urination, vaginal itching or irritation. Screening. So, it is recommended that there is a yearly screening for chlamydia and Neisseria gonorrhea in all sexually active women under the age of 25. And then for women who are over the age of 25, it's recommended for annual screening for only the women who are high risk. So high risk over 25 or 25 and below sexually active in general. By high risk, it means like multiple partners, unprotected intercourse with those partners, not someone who's 40 and married. I mean, you never know, but annual screening is not recommended for that group. So, infectious cervicitis. Now we're talking sexually transmitted infections. Let's start with chlamydia trachomatis. This is the most common bacterial cause of STIs in the United States. Manifestations. So, cervicitis and or urethritis. So, cervicitis, purulent or mucopurulent discharge, pruritus or itchiness, dysuria, dyspareunia, painful intercourse, or hematuria. So you might see blood in the urine, more so with urethritis. 40% of people are asymptomatic, and this is especially true for men. It's the most common cause of reactive arthritis in Western countries. So I actually didn't know that, and I want to real quick go over reactive arthritis because of that reason, because technically women can get reactive arthritis if they have chlamydial cervicitis, right? So, reactive arthritis, classically there's urethritis, uveitis, and arthritis, which in school we learned as can't pee, can't see, can't climb a tree. But it could also cause tendonitis, which is most common in the heels and the soles of the feet. It could cause swollen toes or fingers, mouth sores, rashes on the soles of the feet or palms of the hands, and low back pain. So I like to just tack on there, can't sip tea, can't play Wii, and can't be a yogi. It's really what it is an autoimmune reaction to the infection, and it's seen in 1 to 3% of patients with urogenital chlamydia. Now, it's especially true for men who are HLA-B27 positive, but that doesn't mean it's impossible to happen in women. So, lymphogranuloma venereum is a genital ulcer caused by the L1, L2, and L3 serovars of chlamydia. So, a serovar is kind of like a strain, but it's a little bit more specific than that. That's the easiest way I can describe it. But this is most common in tropical or subtropical regions of the world. For pathophys, it's an extension of the infection from the initial site of infection to the draining lymph nodes. Symptoms: it's going to be a genital rectal lesion with softening and suppuration. You're also going to see lymphadenopathy. It could lead to anorectal syndrome or proctocolitis, which would present with bloody rectal discharge, anal pain, perianal or mucosal ulcers, fever, constipation, and tenesmus. It comes in 2 stages. The primary stage is a painless genital ulcer at the site of inoculation/infection. The second stage occurs 2 to 6 weeks later as an inflammatory reaction with painful, deep inguinal and/or femoral lymphadenopathy. This adenopathy is called bulbos. So, diagnosis of chlamydia. I know that was a lot. Nucleic acid amplification is the most sensitive and specific for chlamydia, N. gonorrhoeae, and M. genitalium. So this can be run via vaginal swab or clean catch urine. Gram stain: over 2 white blood cells per high power field, or HPF, and no organisms because they are intracellular. You will not see them on the gram stain. On urinalysis, you might see leukocyte esterases and over 10 white blood cells per HPF, high power field, on microscopy. So, treatment. First line: doxycycline, 100 milligrams orally twice a day for 7 days. Second line, or if the patient is pregnant, you use azithromycin, 500 milligrams orally as a single dose, and then 250 milligrams orally once a day for 4 days. So that would be 5 days of treatment total, 500 first, and then 250 for 4 more days. Or you could use a single 1 gram dose. I've really only seen this happen in men. I think maybe it's just more effective to do the longer courses for women. But either way, just know you can give a 1 gram dose of azithromycin. But yeah, it does cause a lower cure rate. It's just easier. So treat for gonorrhea unless definitively ruled out with testing. Most tests nowadays include both of them. Like, they run both. So you're likely going to know the status, but in case you don't, treat it. This would be with ceftriaxone, 500 milligrams intramuscularly as a single dose if the patient is below 150 kilograms, and then 1 gram IM if over 150 kilograms. Just so you know, 150 kilograms is 330 pounds. Lymphogranuloma venereum, going to be a more vigorous treatment. So it's doxycycline, 100 milligrams orally twice a day for 21 days. That's first line. Or azithromycin, 1 gram orally weekly for 3 weeks. So that's second line, or if the patient's pregnant. For the bulbos or the lymphadenopathy, consider needle aspiration or IND to prevent rupture or sinus tract formation. And then always, if a patient does have lymphogranuloma venereum, always test for other STIs, including HIV. Gonorrhea is next. So, gram-negative intracellular diplococcus, that's how they're going to describe it if they're describing findings on microscopy. Manifestations: cervicitis, greenish-yellow vaginal discharge with pelvic and/or adnexal pain and swollen Bartholin glands. Urethritis is more common in men, would be a purulent urethral discharge, dysuria, and erythema of the urethral meatus. Disseminated gonococcal infections. So this is similar to reactive arthritis, where I'm thinking, it can happen, so why wouldn't it be on an exam? I'm thinking it could be. So septic arthritis, the knee is classic. It's a warm, swollen, painful knee with signs of cervicitis or urethritis associated with it, like in that patient. And Aside from septic arthritis, disseminated gonococcal infections have a triad of dermatitis, polyarthralgias, and tenosynovitis. So rash, joint pain, tenderness along the tendon sheets, usually with fever, chills, and malaise. Diagnosis, most sensitive and specific, like we said, nucleic acid amplification. Gram stain will show gram-negative intracellular diplococci that indicates N. gonorrhoeae. On urinalysis or dipstick, it's going to be leukocyte esterases and over 10 white blood cells per high-power field. Synovial fluid, so if you're drawing this from a septic-appearing knee. Nucleic acid amplification or culture on chocolate agar. And then, if indicated, pull blood cultures. Management, first line, single dose intramuscular ceftriaxone, 500 milligrams if under 150 kilograms, 1 gram if over. If the chlamydia status is unknown due to a lack of the test, lack of results, etc., then treat presumptively for chlamydia with doxycycline, 100 milligrams twice a day, 7 days. Disseminated infection or septic arthritis, admit the patient IV ceftriaxone. Alrighty, now we get to move on to pelvic inflammatory disease. So, definition. This is an ascending, acute, or subclinical infection of the upper female reproductive tract. Risk factors include multiple sexual partners, unprotected sex, prior PID, age 15 to 25, nulliparous, and IUD placement. Etiologies, it's usually polymicrobial, meaning there's multiple causative agents. Chlamydia trachomatis is the most common, which makes sense given it's the most common STD in general. But Neisseria gonorrhea is also common, Mycoplasma genitalium, anaerobes like Gardnerella vaginalis. The most severe form of PID is going to be most likely gonococcal. Clinical manifestations, the cardinal symptom is pelvic or lower abdominal pain that is usually bilateral, acute onset, worse during intercourse or during movement, and the onset of pain is during or shortly after menses. There's abnormal bleeding, so postcoital bleeding, intermenstrual bleeding, or heavier bleeding. Genital symptoms might include urinary frequency, dysuria, and abnormal vaginal discharge. I mean, think of these causative agents. That will be a hint if they're telling you PID and they want to know what it's from. Think about those causative agents and symptoms from cervicitis. And these patients may or may not have nausea, vomiting, and fever. So, exam. Pelvic organ tenderness is key here. It is the defining characteristic of acute PID. That's uterine, cervical, and or adnexal tenderness. So think cervical motion tenderness is a key word there. The chandelier sign. So that is pain with the pelvic exam, where the patient is in so much pain they reach to the ceiling for relief. You might also see purulent cervical discharge, again, as a hint to what might be causing PID here. This is a clinical diagnosis. The main factors are abdominal tenderness, cervical motion tenderness, and adnexal tenderness, but the patient must also have one of the following to be clinically diagnosed. So, oral temperature over 101, white blood cells over 10K, pelvic abnormality on bimanual exam or ultrasound, an elevated ESR or CRP, abnormal cervical or vaginal secretions or friability, increased white blood cells on saline microscopy of vaginal secretions, and documentation of a recent genital or cervical infection. So, diagnosis other than clinical diagnosis. One of the main things on the differential is an ectopic pregnancy, especially a ruptured one. So work up with a pregnancy test, nucleic acid amplification test for gonorrhea and chlamydia, see if we can find that etiology to guide treatment, and a pelvic ultrasound if suspecting tubo-ovarian abscess, which we'll get into in a minute. Labs include CBC, ESR, CRP, and a urinalysis. The most accurate test is a laparoscopy, but this is rarely performed, but it is considered in uncertain cases, very severe disease, or if the patient is not improving with antibiotics. Management, in a mild case, you can manage outpatient. So first line is going to be, there's a few medications here. So start with ceftriaxone, 500 milligrams or 1 gram IM once, and doxycycline, 100 milligrams twice a day for 14 days. 14. And, or you can use this or you cannot, depending on the clinical picture here, and metronidazole 500 milligrams twice a day for 14 days. That's if you're trying to cover anaerobic. So alternative, if there is a true penicillin allergy, so this patient is going to go into anaphylaxis. That is the only reason why you would not use the first line, because really what you're worried about is the ceftriaxone, because cephalosporins are very similar to penicillins structurally. So only if the patient is going to, or there's a risk of anaphylactic shock, only then would you consider the second line, which is levofloxacin and metronidazole. Inpatient, IV second generation cephalosporins like cefoxitin or cefotetan, and IV doxycycline. Alternatives in pregnancy, or if there's a true penicillin allergy, that would be clindamycin and gentamicin. Complications, tubal factor infertility from scarring of the fallopian tubes. This is especially true when a patient doesn't really know. That was my cat, by the way. If the patient doesn't know they had PID and they had it for a while and it results in scarring of the fallopian tubes, and that's what causes the egg to not be able to get through, therefore can't get fertilized. And tubo-ovarian abscess. That is the other complication. So, hint number 1, persistent PID without treatment or inadequate treatment will cause or will likely result in tubo-ovarian abscesses. Manifestations include setting of PID, right? The patient has PID, and there's an appreciation of adnexal or posterior cul-de-sac mass or fullness. So I didn't really understand what a posterior cul-de-sac tenderness was. So I looked it up, and this image I included here will show that. So it's kind of like this weird spot that you could reach if you're getting like kind of, I guess, like past the uterus. It's a weird location. But basically you have to do a digital rectovaginal exam, and or I suppose you could also probably do a vaginal exam and then like try to prod towards the patient's like posterior. So like you're moving towards the posterior vaginal wall, if that makes any sense. Basically that is an indication that there's an abscess. So it could also be abdominal or pelvic pain, fever, leukocytosis with a left shift. All of those are hints. Diagnosis and management. So the imaging of choice will be a pelvic ultrasound. It'll show a complex multiloculated fluid collection or mass. CT is an alternative in patients where other causes of acute abdomen can't be ruled out. So if you're still suspecting appendicitis, for example. Hospital admission with a gynecology consult and possible surgical excision is the best route to go when this happens. So depending on the gynecology consult, they may consider surgical excision of the abscess or transcutaneous or transvaginal aspiration for large abscesses. So IV antibiotics are going to be the same as the inpatient PID treatment. If you need a reminder, that's going to be an IV second-gen cephalosporin like cefoxitin or cefotetan and IV doxy. All right, and lastly, for PID, Fitzhugh-Curtis syndrome. So this is perihepatitis with hepatic fibrosis, scarring, and peritoneal surface of the anterior right upper quadrant in the setting of PID. So hepatic scarring, fibrosis, and peritoneal surface of the anterior right upper quadrant, like fibrosis there, in the setting of PID, seen in 10% of PID cases. So that's actually a pretty large percentage. Manifestations include right upper quadrant pain due to the perihepatitis with or without radiation to the right shoulder, marked right upper quadrant tenderness on palpation, and diagnosis will be via laparoscopy. And you will see violin string adhesions on the anterior liver surface with normal or only slightly increased LFTs or liver function testing. And I included an image here too of violin string adhesions. Okay, so finally we have made it to our last little bit of the infectious disease portion of this blueprint. So let's start with Bartholin cyst or abscesses. So clinical manifestations, this is either an infected gland or a non-infected gland. So if you don't know, the Bartholin glands are towards the posterior aspect of the vagina, and they are, I suppose what I would say is they're not like external, like they're slightly internal, around towards the introitus of the vagina. Um, but manifestations would be an infected gland, so it will be very painful, tender, like it would be fluctuant if an abscess is present, localized pain and tenderness, painful intercourse, and it will be unilateral most likely. So unilateral vulvar mass. Non-infected won't be tender. It will be a unilateral vulvar mass at the Bartholin duct location. Diagnosis, other than clinical, would be a complete blood count and culture of the drained fluid, and you can use that to test for STIs. Management if it is infected, IND with or without placement of a word catheter for continued drainage under local anesthesia. That is the first line management. There should be immediate pain relief with the drainage of the contents of the cyst or abscess. Antibiotic therapy is indicated if there's a severe infection or if the patients have risk factors for recurrent abscesses or if they have had recurrent abscesses. And it's important to note here, while you can opt to place a word catheter during the first IND of someone's like first Bartholin gland cyst / abscess, a word catheter is more, I guess, recommended also for recurrent abscesses. And there's also a procedure for people with recurrent cysts called marsupialization. Asymptomatic cysts don't need any intervention. So non-infected cysts, I mean, really don't need anything done. Okay, from there, syphilis is next. So the definition and etiology. This is a chronic infection caused by Treponema pallidum, which is a spirochete. It is known as the great imitator because the disease itself presents like so many other things. It's easy to mistake as something else. The transmission is through direct contact of mucocutaneous lesions via sexual contact, so vaginal, anogenital, or orogenital, and it can be transmitted vertically, which means it can be transmitted from mother to baby via the placenta. Pathophys, the spirochete enters tissues through the direct contact, and it forms a chancre at the inoculation site, and then it travels to the regional lymph nodes and then disseminates. The manifestations will go through the 3 different phases. So primary syphilis is in the first 10 to 90 days. It will present with a chancre which is a solitary, painless 1 to 2 centimeter ulcer at the site of inoculation with a non-exudative base and a raised, indurated edge and margins. It will kind of start as a papule and then it will ulcerate. It arises within 2 to 3 weeks of exposure. Concomitant HIV may lead to multiple lesions or ulcers, and chancres heal without scarring within 3 to 6 weeks, even without medical management. That said, if you do treat with penicillin, spoiler alert, that's the treatment, it can resolve in days. You might also see non-tender bilateral regional lymphadenopathy near the chancre site, and that might last 3 to 4 weeks. Note here that neurosyphilis can occur at any time following infection. So at least I think of it towards tertiary syphilis, but it can technically happen with primary as well. So secondary syphilis can start from a few weeks to 6 months after initial symptoms. It'll present with a maculopapular rash, which is the most characteristic finding. This is a painless, diffuse maculopapular or papulosquamous exanthematous lesions on the face and trunk, with or without coverage of the palms and soles. And there are individual lesions that are discrete, reddish-brown or red, and approximately 0.5 to 2 centimeters. Systemic symptoms, this will include fever, headache, malaise, anorexia, generalized and possibly tender lymphadenopathy, arthritis, meningitis, headache, hepatitis, and alopecia. There is also something called condyloma lata, which is a wart-like moist lesion that involves mucous membranes and other moist areas. These are highly contagious. And I guess this isn't really a phase, but we'll kind of sneak it in there. So the latent or asymptomatic syphilis is kind of in between stages. It's called early latent if it's before the 1 year mark of infection, and it's called late if the patient has had syphilis for 1 or more years. So without diagnosis and treatment, primary or secondary syphilis may progress to a latent stage with distinct features here. So it's implying that first you had symptoms and now you have no symptoms, but you have positive serologic tests for syphilis and normal cerebrospinal fluid. Tertiary or late syphilis occurs 1 to 30 years after initial infection or after latent infection. Cardiovascular, the main sign is aortitis, but you could also see aortic regurg, aortic aneurysms, coronary artery narrowing, and thrombosis. You get something called gamma, which is a non-cancerous granuloma on the skin and the body tissues. It could even occur on the bones. Late neurosyphilis will present with headache, aseptic meningitis, vision, or hearing loss. It can cause general paresis, which is a syndrome of progressive dementia, seizures, and psychiatric symptoms. Tabes dorsalis is demyelination of the posterior columns of the spine and spinal nerve roots. This leads to areflexia, burning pain, weakness, severe unprovoked radicular pain, ataxia, secondary to the loss of proprioception. And then meningovascular involvement will present as hemiplegia, aphasia, and seizures. Finally, you might see an Argyll-Robertson pupil, which are bilateral, small, irregular pupils that constrict with accommodation. So when you, for example, shine light in the left eye, the right eye will constrict, but they do not react when exposed directly to the bright light. So if you're shining a bright light in the left eye won't constrict, but the right eye will. Diagnosis: non-treponemal tests are for screening and they are non-confirmatory. So the most common, at least from what I've seen, is the RPR, which is a rapid plasma reagent. This is an antibody titer that is positive 4 to 6 weeks after infection. Changes indicate the therapeutic response to treatment, so you can kind of monitor this while the patient is receiving treatment. There's also the VDRL, which is a venereal disease research lab, and it's kind of a less sensitive antibody titer. Either way, if one of these is positive, it must be confirmed by specific treponemal testing. False positives are possible in both, and they could be from antiphospholipid syndrome or pregnancy. Treponemal specific testing, aka the confirmatory tests, the most commonly used one is the fluorescent treponemal antibody absorption, or FTA-ABS. You could also do a T pallidum particle agglutination assay, which is a TPPA. Dark field microscopy allows for direct visualization of T pallidum from the chancres, mucosal lesions, or condyloma lata. I went in on this because, okay, so you can see this in this image here. So it's really not used anymore because it's technically demanding, dependent on the viewer, and it's really only useful with experienced techs. It does have a high sensitivity in primary infection because there is a ton of spire sheets, but the levels decline as the infection progresses. And you cannot use the saliva samples because of the high false positive rates, because you do have non-pathogenic treponemes that live in the mouth, and you wouldn't be able to distinguish them from Treponema pallidum on dark field. Now, this part likely won't be on an exam, but I found it very interesting. The best use for dark field microscopy nowadays are when other tests are inconclusive, or in babies where diagnosis is really difficult and you just need to get like a sample. This will be easier, basically. Okay, so moving on to the management. Treatment of choice for all stages is penicillin. Primary, secondary, and early latent syphilis without neurosyphilis, you'll treat with a single dose of intramuscular penicillin G benzathine, 2.4 million units. If penicillin allergic, like a real allergy, doxycycline, 1 milligram BID for 14 days. I think it's 100 milligrams. Sorry. Late syphilis, you'll treat with penicillin G benzathine, 2.4 million units, intramuscularly once a week for 3 weeks. For ocular or neurosyphilis, treat with IV aqueous penicillin G. Monitoring for patients, you want to test for HIV and other STIs, and then re-examine at 6 and 12 months of treatment. Now, real quick, a complication is a Jarisch-Herxheimer reaction. This is an acute self-limited febrile reaction that occurs within the first 24 hours of receiving therapy for a spirochetal infection. It's due to the rapid release of cytokines, immune complexes, and endotoxins from the killed organisms. Presentation will be fever, chills, headache, myalgias, hypotension, and the worsening of the syphilis rash. Management, it usually resolves on its own within 12 to 24 hours. It's self-limited, but you can treat symptomatically with NSAIDs or acetaminophen. Now, next, we're going to talk about a chancroid. I frequently mix this up with a chancre, but a chancroid is different. This is a sexually transmitted infection leading to genital ulcers, lymphadenopathy, and bulbo formation. The etiology is Haemophilus ducreae, which is a gram-negative fastidious coccobacillus, and it's transmitted after a break in the skin. It's most common in children and young adults, and it has a 10% co-infection with HSV or syphilis. Incubation period for this is 3 to 7 days. It'll present with one or more painful genital ulcers at the inoculation site. They'll have well-defined but irregular borders that are sometimes undermined with an erythematous base, with or without gray or yellow purulent exudate. They may bleed easily. So in presentation, these are very different from a chancre. For example, the chancres are non-exudative, they are non-painful, but the names can be confusing. But either way, chancroids are followed by painful enlarged inguinal lymphadenopathy, which can liquefy and then become fluctuant, which would be a bubo formation. Diagnosis is usually clinical because it's very difficult to culture, but you can do a PCR. You have to rule out HSV by PCR or culture and rule out syphilis. Management will be with azithromycin 1 gram orally for 1 dose or ceftriaxone 250 milligrams intramuscularly. Now for herpes simplex virus. We'll start with HSV1 and then go into HSV2. HSV1 is transmitted via contact with contaminated saliva. Primary infection is usually asymptomatic, but it may cause tonsillopharyngitis. Secondary or recurrent infection. The hallmark is herpes labialis. I think we've all heard of this. It's a cold sore. They might have prodromal symptoms of itchiness, burning, tingling, pain, and then within 24 hours, the development of grouped vesicles on an erythematous base that crust over before healing. Specific cutaneous lesions, super quick. Herpetic whitlow would be on the finger. It's exposure to infected secretions. Herpes gladiatorium is a vesiculopustular rash on the face, neck, arms, etc., passed through like skin to skin, so like wrestlers, rugby players. Eczema herpeticum occurs in patients with atopic dermatitis. It's an HSV-related skin rash characterized by cutaneous pain and new vesicular skin lesions. Diagnosis, the test of choice here is a PCR, but you can also do viral cultures, direct fluorescent antibodies, or zinc smears, which would show multinucleated giant cells. This is a non-specific finding for HSV, and it's more classic for HSV2. Management for acute episodes or breakouts would be oral valacyclovir 2 grams twice a day for 1 day. HSV2 is a sexually transmitted viral infection from direct contact with infected lesions. Most cases are from HSV2, but it can still actually be caused by HSV1. So I'm talking the like genital lesions here. They can be caused by HSV1, and actually about 25% of the US population has some form of genital herpes. Manifestations, so prodromal symptoms of burning, paresthesias, and numbness before the development of painful genital ulcers. It's uncommon, but it is possible to have dysuria or fever. The ulcers will be multiple, shallow, tender, and grouped, 2 to 4 millimeters. There'll be vesicles on an erythematous base that turn into vesiculopustules, erosions, and ulcerations with scalloped borders. You might also see inguinal lymphadenopathy. Diagnosis is PCR, that's the test of choice, but you can do the same test as HSV1. The zinc smear classically shows multinucleated giant cells, which are intranuclear eosinophilic Cowardry A inclusions, but other herpes infections can show the same thing, like HSV1, like I was saying, and varicella zoster. I did include a photo here, though, of the multinucleated giant cells. Okay, next, we're going to talk about a real quick management. Valacyclovir is preferred, but you could also use acyclovir or famciclovir. Okay, now HIV. I'll try and keep this as brief as possible because I think if there are any questions, there will more so be a diagnosis question or a presentation question than treatment, for example. But human immunodeficiency virus is a retrovirus that changes viral RNA into DNA via reverse transcriptase. HIV-1 is most common, but there is an HIV-2. Presentations are highly variable, and people can present at different stages. So the acute seroconversion stage. This is a high asymptomatic rate, but it can look like flu-like or mononucleosis-like illness termed acute retroviral syndrome. This is highly, highly, highly infectious due to the transient high viral loads. And like I said, this will look like kind of any run-of-the-mill illness like sore throat, lymphadenopathy, mucocutaneous ulcerations, joint pain, diarrhea, etc. Now, something that is classic for HIV are opportunistic infections. So it's most commonly oral and esophageal candidiasis. So think about you're getting an exam question and you see a young adult without any other immunodeficiencies, right? And they don't use any like oral steroids for asthma or something, like an inhaler. Think HIV if they come in with oral or esophageal candidiasis. Others, though, include CMV, which can cause proctitis, colitis, hepatitis, esophagitis. Need I go on? PCP pneumonia, which is definitely classic. Cryptosporidiosis, and other fungal pneumonias, really just things that are kind of specific to HIV because most people they have the immune system to be able to fight these things off. So, AIDS is defined as a CD4 count below 200, and that will cause recurrent, severe, and potentially fatal infections, or even opportunistic malignancies. So, these are called AIDS defining conditions. So, super quick, there's AIDS associated dementia / encephalopathy, HIV wasting syndrome, which is just idiopathic diarrhea and weight loss. Otherwise, uncommon or rare infections, PCP pneumonia, candidiasis are classic. Malignancies, Kaposi's sarcoma is from HSV 8, but you could also see lymphoma or invasive cervical and anal carcinomas. And then kidney disease, this is more so a note for clinical practice than for exams, and just because I'm a nephrology nerd, but you can get HIV-associated nephropathy, which is also known as HIVAN. I've actually seen this before twice during my nephrology rotation, so I guess it is uncommon, but it's not rare amongst people with HIV. Or maybe I just happened to see it twice. I don't know. But it's nephropathy secondary to either direct intrarenal HIV gene expression or lesions related to the immune dysregulation, recurrent infections, drug effects, etc. And HIV is classically associated with rapidly progressive end-stage renal disease. And if you learned anything in class, it's likely FSGS is associated with HIV, which is focal segmental glomerulosclerosis. This is a subset of HIVAN, basically. So you're going to have to diagnose it with a kidney biopsy, and HIVAN can be prevented and even sometimes reversed by combined antiretroviral therapy or ART. So, diagnosis. This is the part that is good to know for the exams. Routine screening test of choice is the 4th-gen antigen-antibody combination HIV 1 and 2 immunoassay. This tests for HIV 1 and 2 antibodies and the HIV P24 antigen, which is a viral core protein that builds in the blood as the viral RNA level rises after infection. And this is best because the antibody-only testing might be negative during the window period, which is when the tests can be negative even when the patient is infected, and that's because the response hasn't built enough yet. But that's neither here nor there. So if the screening test comes back negative, just consider the patient HIV negative, no further testing. If the 4th-gen assay screen is positive, then you could order confirmatory HIV 1 or HIV 2 antibody differentiation. So I'm not going to get too far into this because I was finding a lot of conflicting information. If the confirmatory test is positive, Pance Prep Pearl says to order a plasma HIV RNA. The CDC does not indicate that there's any testing necessary. And to be honest, given that it's a confirmatory test, it really doesn't make sense to me to keep testing, especially because if the test is indeterminate or negative, you order a plasma HIV RNA test according to Pance Prep Pearls, but according to the CDC, you would order an HIV nucleic acid test. For suspected early HIV, so this isn't a patient you're screening, this is a patient that you're potentially diagnosing. Combination antigen antibody immunoassay and an HIV RNA viral load testing, which is RT-PCR. If there's high suspicion but both are negative, then repeat them both in 1 to 2 weeks. If the screening immunoassay is negative but there's a positive HIV RNA, this indicates early HIV. For a positive screen and a positive HIV RNA, this is an early or established infection confirmed with a second test, either HIV RNA or serology, several weeks later. You could use an HIV RNA viral load. This would be positive during the window period. Other associated or suggestive labs include elevated liver enzymes, mild anemia, thrombocytopenia, and you really can't rely on the leukocyte or lymphocyte counts here because they're highly variable, at least at first. Management. Antiretroviral therapy should be offered to all patients who test positive, regardless of symptoms or lack of symptoms or their CD4 count. Doesn't matter. They should all be offered it. And there are 25 medications currently available. We're not going to get into those at all because there's a lot. I don't think we'll ask about them. Monitoring, you can use the HIV RNA viral load testing to monitor infectivity and treatment. Okay, we finally made it to acute cystitis. So, pathophysiology, it's usually an ascending infection of the lower urinary tract from the urethra. Risk factors for women include sexual intercourse, although I actually did read that there is no evidence that urinating after intercourse prevents UTIs. I think that's a wives' tale. Anyway, complicated risk factors. So an underlying condition with a risk of therapeutic failure. So that includes pregnancy, diabetics, immunosuppression, indwelling catheters, etc. Etiologies, the most common is E. coli. Other uropathogens are common, and the second most common in sexually active women is Staphylococcus saprophyticus. Clinical manifestations. Irritative symptoms include dysuria, frequency, urgency, hematuria, and suprapubic pain may also be seen. Physical exam, you might be able to elicit suprapubic tenderness, but otherwise it's mostly unremarkable. Diagnosis, urinalysis will show pyuria, which is over 10 white blood cells per high power field. Might also show hematuria, leukocyte esterases, nitrites, cloudy urine, bacteria, or increased pH, depending on the bacteria. Urine culture is the definitive diagnosis. Women, it'll show over 1,000 uropathogens, CFU per milliliter of uropathogens, via clean catch specimen. That is important. There will likely also be a test for epithelial or squamous cells, which would indicate contamination. Elevated epithelial cells indicates contamination. When you order a urine culture, the indications are for complicated UTI for infants, children, elderly, men, urologic abnormalities, people refractory to treatment, or patients with catheters. Management of uncomplicated, first line will be nitrofurantoin or trimethoprim sulfamethoxazole, aka Bactrim, or fosfomycin. Second line is a fluoroquinolone like Cipro or levofloxacin, and that can be used first line if the patient has sulfa allergies. Adjunct treatment, so not antibiotics. Patient can increase fluid intake, and hot sitz baths might provide relief of discomfort. Phenazopyridine is a bladder analgesic that is not used more than 48 hours due to side effects, which include methemoglobinemia and hemolytic anemia. The patient needs to be informed that azos will turn the urine bright orange. Complicated UTIs should be treated with fluoroquinolones, PO, aka orally, or IV. You could also do aminoglycosides for 7 to 10 days or 14 days, depending on the severity. Cystitis during pregnancy, you could treat with amoxicillin, augmentin, cephalexin, nitrofurantoin, and fosfomycin. Avoid Bactrim in the first trimester, and avoid aminoglycosides, fluoroquinolones, and doxycycline. Quick note here on Bactrim. So it is a folate synthesis inhibitor in bacteria. It's broad spectrum with great gram-negative and gram-positive coverage. It has the second best oral coverage against MRSA. Linezolid is the first, but it's not really used as much as Bactrim. So it's usually used in UTIs, soft tissue infections. Adverse reactions, these are the important things, can cause a rash, itchiness, GI symptoms, photosensitivity, and folate deficiency. Those are the primary adverse reactions. Contraindications include pregnancy for the first trimester and the last month. It's contraindicated in pregnant mothers, or nursing mothers and neonates under 6 weeks. And that's because it can cause kernicterus. And obviously contraindicated in sulfa allergies. Now, nitrofurantoin, this is not effective against Proteus or Pseudomonas, but it does have decent gram-positive and gram-negative coverage. It's used for uncomplicated acute cystitis and prophylaxis only. So it is safe in pregnancy except for at term. Adverse reactions include nausea, vomiting, loss of appetite, diarrhea, and headache. Really nothing crazy here. It does have the potential to cause pulmonary toxicity in the form of hypersensitivity, pneumonitis, and chronic pulmonary fibrosis, especially if the patient is over 65. Contraindications include pregnant patients at term, meaning 38 to 42 weeks, during labor and delivery, or in neonates under 1 month. Okay, now moving on to asymptomatic bacteriuria before we get into pyelonephritis. Asymptomatic patients with incidental bacteriuria on urinalysis. So we're just going to split this into no treatment is needed versus you need to treat. No treatment is needed for the general population, for the elderly, diabetics, non-pregnant, premenopausal women, people with spinal cord injuries, etc. You do need treatment for pregnant patients, patients undergoing urologic interventions, and patients with hip arthroplasty. Pregnancy requires screening and treatment for bacteriuria, but we'll get more into that in my obstetric video, which is coming soon. All right, pyelonephritis. Infection of the upper genitourinary tract. This is the kidney, parenchyma, and renal pelvis. It's usually an ascending infection from the lower urinary tract, aka cystitis. Etiologies, the most common is E. coli, just like acute cystitis. Risk factors are pretty much the same: diabetes mellitus, history of recurrent UTIs or kidney stones, pregnancy, or urinary tract malformations. Upper tract symptoms include fever, chills, back or flank pain. It's not common, but it is suggestive to have nausea and vomiting. About 20 to 30% of people get bacteremia. And even more suggestive of the diagnosis are lower tract symptoms as well, so dysuria, urgency, and frequency. This indicates the etiology of the problem. So if the patient has an untreated UTI, like acute cystitis, then maybe pyelonephritis goes up on the differential. Physical examination, positive costovertebral angle tenderness is the key thing here, but you'll also see fever and tachycardia. UA will show pyuria, aka over 10 white blood cells per high power field. Might also show leukocyte esterases, nitrites, hematuria. The urine will be cloudy. It will also show bacteriuria. The hallmark of pyelonephritis are white blood cell casts, which I do have here on the slide that you could look at. So you might also order a urine culture, which would be the definitive diagnosis, and CBC might show leukocytosis. Outpatient management is in mild cases. You would treat with a fluoroquinolone first line, like Cipro or levofloxacin. Under no conditions do you use nitrofurantoin because it cannot cross over into the kidney. Inpatient management includes third or fourth generation cephalosporins like ceftriaxone, extended spectrum penicillins like piperacillin tazobactam, fluoroquinolones, or aminoglycosides for a total duration of 2 weeks. The indication for admission would be if the patient is on the older side, if there's signs of obstruction, if the patient has comorbid conditions, or if they can't tolerate the oral antibiotics. In pregnancy, IV ceftriaxone is first line. As trionam if penicillin allergic. I highly doubt you're going to get that question. But I do think it's important to know that IV ceftriaxone is first line for pyelonephritis in pregnancy. All right, finally, our last one of the infectious disease section here. Toxic shock syndrome is relatively rare, but a potentially fatal reaction to preformed Staph aureus toxin, TSST1, not the actual bacterium. It has an equal incidence of menstruation-related cases and non-menstruation-related cases, so like surgery or burns. Manifestations, the key ones here are the abrupt onset of fever, vomiting, watery diarrhea, myalgias, chills, and confusion. Diffuse macular erythematous rash involving the palms and soles. Might have non-purulent conjunctivitis. And there are signs of multi-organ dysfunction. Think similar to sepsis. Cardiac arrhythmias, cardiomyopathy, respiratory failure, DIC and coagulopathy, acute kidney injury, elevated liver enzymes to indicate acute liver injury. During recovery of illness, there will be desquamation of the palms and soles within 1 to 2 weeks of the initial infection. Diagnosis, clinical diagnosis, fever over 102 degrees Fahrenheit, hypotension, systolic under 90, skin findings, and involvement of 3 or more organ systems. Those are the criteria that you need. History of risk factors is also useful here, so recent menstruation or tampon use in the case of women's health. Lab findings include, for a CBC, you're going to see leukocytosis with a left shift. BMP and LFTs may be used to assess organ function. Blood cultures are negative. That is the main thing here because it looks so much like sepsis other than the few real distinguishing factors like conjunctivitis, the rash. But really, the blood cultures are negative. That's very important. The ABG may also show metabolic acidosis. Treatment, remove the foreign body and control the source of infection. Aggressive volume resuscitation to improve hypotension, and empiric antibiotics include clindamycin, which is great for toxin suppression, and vancomycin. If there's a culture with methicillin susceptible Staph aureus, then treat with clindamycin and oxacillin or nafcillin. So clindamycin and, in parentheses, oxacillin or nafcillin. For MRSA, treat with clindamycin and vancomycin. Okay, so we are all finished with the infectious disease portion here, I'm going to start a new video for the breast disorder section, and we will go from there all the way to the end of the study guide. So thank you for listening, and please continue to the next video, and we'll get started with breast disorders. Thank you.